Yeah, but not because of the metal. It's because it's going to disable it. Yeah, no pacemakers because it's going to disable it. And remember what we said? We said take off all your transdermals before an MRI. Remove your transdermals before the MRI. And it'll disable your pacemaker. It'll totally jack that up. Oh, and here's another thing that I had to remind you. Typically, artificial hips and knees are not a problem with an MRI. So your prosthesis, that's not an issue with MRI. I meant to tell y'all that. Cochlear implants, that's a problem. No cochlear implants. So no pacemaker, no cochlear implants, no metal. But your little artificial hips and knees and stuff, they're fine. Okay, EEG. Electroencephalogram. Here you go, right here. This is the procedure of choice with seizures, coma, sleep study, to determine brain death, that's your procedure of choice. Anybody having a seizure, anybody in a coma, anybody having a sleep study for sleep apnea, and to determine brain death, EEG, electroencephalogram. EMG, let the M guide you. Myelogram. What does myo mean? This is the procedure of choice for muscle weakness, neuromuscular conditions like MS, MG, ALS, GB, Guillain-Barré, carpal tunnel,
What did you say after MS?
MG, myasthenia gravis. EMG, electromyogram. Any muscle weakness, muscular, neuromuscular disorders. Your patient comes in talking about their hand is numb, or this burning, or their arm gave out, or they feel like they're just, they're complaining of basically a paresthesia. Then they're going to get an EMG. By the way, I don't know because I refuse to get it. It hurts like hell. Remember, I refused. I was a bad patient. You too? Oh, yeah. Oh, yeah. Yeah, I got the little order and everything. Fuck you. I'm not doing that shit. Here's what we do. We put needles in your muscles. And then we administer a little shock. No, I think not. Now, the people that have had it done, that are not wimpy like your girl, say it wasn't that bad. The people, and then there's another set of people that did have it done and are wimpy like me probably, and said it was the worst thing ever. I'll just tell you what the secretary said at a neighboring hospital when I went to have another procedure done in neuro. She said, girl, you better be glad you're here for that procedure and not an EMG, because them doctors be in there, and even the doctors be screaming with them EMGs. Why you gonna tell me that? What if I get ordered an EMG? The secretary told me that. She said, honey, even the doctors be screaming when they get those EMGs. Great. Hope I never need it. Who does that? I was like, oh my God. So no, I don't want it, ever. Now, PET scan. Positron emissions, topography, which you don't care. The positron and emissions, you'll remember it. PET scan. It's a nuclear test. God bless you, dear. Whenever I say something is nuclear, that means no pregnant women, because that means radioactive. So I'm going to give you a couple of things that you probably should know are nuclear. PET scan is nuclear. VQ scan is nuclear. Muga scan is nuclear. Just gave you 3 hookups right there. PET scan, VQ scan, and Muga. All of those are nuclear. So this PET scan, this nuclear scan, works off of the metabolism of sugar. We're going to give you an IV. We're going to give you an infusion of a sugar-based dye. The indication for a PET scan, the most common reason why I would use it is I've diagnosed cancer in my patient, and every 6 months I'm going to order a PET scan to check for metastasis of cancer in other parts of their body. When I give them this glucose infusion, if there's cancer in other parts of their body, it's going to light up like a Christmas tree. Because cancer needs sugar to survive. And it thrives off any sugar in your body. Now you know why diabetics are a big deal. So in the patient that has cancer that has spread, the part where it's spread to is going to light up like a little Christmas tree. Okay? So again, PET scan, one of the indications is to check for metastasis with a glucose-based dye. The other indication for a PET scan is when I think a patient has Alzheimer's. It's not diagnostic because if you'll recall, we can only diagnose Alzheimer's on an autopsy. But it is useful when I work it up. So if I'm working up somebody I think has Alzheimer's, I'm going to use a PET scan. And I'm going to see tangles in the brain, tangles and plaques in the brain, PET scan. So Alzheimer's and cancer, okay? Okay, boo-boo kitties, here we go. Glasgow. Let's do us a Glasgow scale right quick. Y'all getting done today. This is so easy right here. Okay. So our Glasgow scale, most of you remember this already, just a nice little quick review. Glasgow scale is EVM 4, 5, 6, total of 15, 12 to 15 stable, 3 to 8 coma, I verbal, motor or movement. Highest number of points, 4 for eye movement. Highest number of points, 5 for verbal. Highest number of points, 6 for motor. The lowest score you can get in any of them is not 0, it's 1. So the lowest score, 1, lowest score, 1, lowest score, 1, boom, 3. 12 to 15 is stable. I'm probably going to get you out my unit and send you to the floor. 3 to 8 is a coma. At 5, we call organ procurement. If you wanted to donate your organs. Lumbar puncture at the bottom. You know that's a big one. Huge. For lumbar puncture, you had to remember the positioning. And for some patients, it's fetal position, which as you already know is lateral recumbent. Lateral recumbent. Others are sitting up. So it just depends on what your doc wants to do. You can do lateral recumbent, which is fetal position. And every time you see the word recumbent, the knees are bent. Or the patient can be sitting up. Now, when it comes to the lumbar puncture patient, this is usually somebody who either has meningitis or they have maybe some type of encephalitis. Guillain-Barré. Those are different reasons why we do it. We even do it for, what do you call it? Oh, God. MS. Part of the workup for an MS patient or suspicious for MS. The physician can go between, and yes, you had to know this. The physician may go between L4 and L5 or L3 and L4. This is more common. On your test?
No, in my life.
Oh, in your life? Oh, my God. Oh, baby, you have to tell me about that. That's another thing I ain't trying to do. Okay, so your lumbar puncture or spinal tap. The doc's going to go in between L4 and L5 or either L3 and L4. Both are okay. It's just I see it more commonly L4 and L5. I've seen this done a million times. It's not that uncommon to get an LP. And I'm sure if it was going to save my life, I would say okay, but it scares me. Now, your job is to remember, after the procedure, the patient needs to be supine for 8 hours. Supine for 8 hours. Remember, when there's an infection like there would be with bacterial meningitis, the fluid is cloudy. Again, when there's an infection like there would be with bacterial meningitis, the fluid will be cloudy. When there is Guillain-Barré, you're going to have a high protein, a very high protein. Now, if you go up just right above it, you'll see myelogram right above it. This is done sort of like a lumbar puncture, but instead of taking fluid out, I infuse dye in. So this is when I'm looking for a spinal fusion or there's been a spinal cord injury. It's called myelogram. And I'll say that again. It's done exactly like a lumbar puncture, but instead of taking fluid out, I'm putting contrast dye in. And I'm following to see if there's a stenosis or a compression of the spinal cord. I may do it for sciatica. Yes, you had to know that. I may do it for sciatica. I may do this for spinal cord injury, herniated disc. Because I didn't take fluid out, the patient does not have to be flat. They can actually have a pillow. For a lumbar puncture, you're flat. So myelogram, you just have to, you can keep the head of the bed up about 30 degrees. It's not going to hurt anything. Both of these, you're monitoring for leakage of fluid. ICP, oh, let me do one more down at the bottom. Logrolling. Logrolling, it's important that you know you need 3 people and 2 of them must be nurses. You need 3 people and 2 must be nurses. Typically for logrolling, the patient may have, on your exam, had something called, and please write it, a laminectomy. With the laminectomy, following the procedure, you may have to do logrolling. When it comes to logrolling, one nurse is at the head of the bed and in charge of alignment. One nurse is at the head of the bed and she's in charge of correct alignment and coordinating the movement of the patient. The other 2 people are on the same side of the bed. The other two people are on the same side of the bed, and a pillow is put between the knees and ankles. ICP monitoring, which is right up a little bit from same side. ICP, this is easy. When is it a problem? What number? Greater than 20. ICP. Make sure you know true ICP monitoring is invasive. True ICP monitoring is invasive. And it's a risk of infection. It's a monitor put in your head. OMG is greater than 20. OMG if greater than 20.